Royal Wounds family, this is Diabetic Foot Files. And just a quick disclaimer, even though it should be common sense, educational purposes only, not this is not just medical advice, okay? If you have a leg wound, especially with diabetes, redness, swelling, odor, fever pain, get evaluated immediately. Okay, so I'm not teaching nobody to take care of the wounds themselves, okay? And I think y'all know that, okay? Mm. Okay, so Royal Wounds family, today we're also going to talk about Queen Victoria, not just as a meme, not as a symbol, but as a case study is something we see every day in wound care. Okay, so now historians discuss Victoria's later life health problems, including leg weakness and significant mobility limitations. One period account notes that in her last year, she wasn't able to walk without help. One leg described as very weak. And here's why that matters for our patients. When people stop moving, their legs start swelling. When the legs start swelling, skin breaks down. And when the skin breaks down, bacteria moves in. And when diabetes or vascular disease mixed into it, a wound becomes a revolving door. Okay? So today we're going to talk about a clinically juicy episode, what history says about her life limitations, what venous leg ulcers are and how they form, the triad behind most chronic venous leg wounds, why movement is literally a wound healing treatment. Remember, we talked about collateral, the biomechanics of the calf muscle pump, which I love, ankle range of motion, why immobility delays healing chemically and mechanically, and how we would treat Queen Victoria today, step by step, modern limb salvage style. So let's continue. And I know I've been missing, but it was the holiday season. But yay, let's keep this going. Let's do Queen Victoria. So, what history actually supports, okay? What we can responsibly state from sources. A record recollection describes Queen Victoria in her last years as not able to walk without help and have one very weak leg. On a side note, anybody watched that movie called The Favorite? That was good. Yeah. Late life biographies commonly describe her last years as marked by physical decline, aka with her mobility, her vision, and overall free. She was fragile, fertility, and consistent with aging and chronic disease. I'm not going to pretend that we have modern clinic notes that says that she has a venous leg ulcer, left medial malleolus by 3 by 2 centimeters. We don't have that. What we do have is a reliable documentation of late life mobility limitations. And that is one of the strongest drivers of venous hypertension, edema, skin compromise, and chronic leg wounds in real life patients. So this episode uses Queen Victoria as a high vitality clinical mirror for very real wound pathways. Immobility equals leads to venous stasis slash edema, which leads to skin failure, which leads to ulceration. Okay? So I think people would know what venous leg ulcers are, but I always try to get into it. So venous leg ulcers, what they are, where they happen, and why they linger. Okay, they're very hard to heal. So the classic triad behind venous leg ulcer disease. There are a few ways clinicians phrase this triad, but the most useful wound care version is one, venous hypertension, so ambulatory venous hypertension. Two, valve failure and or venous obstruction, which equals reflux or poor outflow. Three, calf muscle pump dysfunction, often from immobility and weak ankle range of motion. Why the calf pump matters. Venous insufficiency alone isn't always enough. Calf pump the calf pump. Calf pump failure is strongly linked to severity and ulceration. So where venous leg ulcers usually show up, is the gaiter region. I'll spell that for you. Gaiter, the gaiter area, which is the lower leg, often near the medial malleolus. Associated signs are edema, skin discoloration, eczema-like changes, and lipodermal sclerosis. Why they become chronic? Persistent edema separates oxygen and nutrients from the cells. Inflammatory signaling becomes persistent, and local skin becomes fragile and fibrotic, and microcirculation becomes compromised. So, how does movement comes a part of wound care, the biomechanics behind it? So, the calf muscle pump, pretty much is like a second heart, okay? When the gastrocnemius slash soleus complex contracts, the deep veins are compressed, the venous blood is pushed up, and the venous pressure drops during walking, what we call ambulatory pressure improves. When you don't walk, the venous pressure stays high. Fluid leaks into the tissue, which causes edema, and healing gets harder. This isn't a motivational poster science. This is physiology and clinical evidence. The calf pump muscle function is a key determinant in venous ulcer, leg ulcer severity. Okay? Ankle range of motion, which your doctor should always check for, is a hidden ulcer predictor. Stiff ankles equals weaker pump, which equals more venous stasis. Reviews have linked ankle range of motion and calf pump mechanics to venous leg ulcer healing and shows why exercise and physiotherapy can be therapeutic. That's why I like PT so much. Imagine your patient's lower leg is a swamp and movement is a drainage system. So no movement makes the swamp rises, skin starts drowning, and the wound becomes wet, inflamed, and bacteria friendly environment. So, what's the real science about why immobility delays healing? The real science, mechanical and chemical. So, pressure plus microcirculation failure. Immobility increases sustained pressure, reduces capillary flow, and promotes tissue ischemia. Mechanisms well described in pressure injury science. Different types of ulcer type, but the perfusion principle is universal. Edema, and lymphatic traffic jam. Chronic leg edema doesn't just look puffy, it changes diffusion distance for tissue and nutrients. It alters the tissue mechanics and can keep wounds wet and exudative. Modern wound literature emphasizes the importance of fluid balance and drainage and healing. The venous inflammation loop. Chronic venous disease drives inflammatory skin changes. The wound environment becomes stuck in that cycle of inflammation and skin breakdown. And now the diabetes multiplier. So if Queen Victoria were a modern patient and if she had diabetes, immobility plus edema would collide together with also impaired angiogenesis, impaired immune response, neuropathy, which causes more unnoticed trauma, and hyperglycemia that affects the leukocytes and the collagen cross linking. This is why diabetes and venous disease is such a stubborn combination. So, what did they do back then for the Victorian era reality? Let's anchor this in what medicine could offer during the Victoria era. So, what wound care looked like in the late 1800s? Dressing, bandaging, like herbals, ointments were common practical approaches. Infection control was evolving dramatically after Joseph Leicester, like the Listerine guy, Joseph Leicester, I think so. Antiseptic system was using carbolic acid was introduced and published in 1867, transforming wound care infection outcomes overall. So if you're picturing wound care in Victoria's time, it's bandages, rest, limited mobility support, variable cleanliness, and an era where antisepsis was emerging but not fully standardized. And the missing superpower back then, they didn't have a duplex ultrasound mapping or reflux to map reflux or obstruction. They didn't have modern compression systems with standardized pressure. They didn't have evidence based dressing selection frameworks. They didn't have effective antibiotics, which we know from them, and they didn't have vascular interventions like today. So, how would we treat Queen Victoria today? Like, what's the modern plan? Vascular, vascular, vascular. You already know me, vascular. So, first step, diagnose the ulcer type correctly. Venous versus arterial versus mixed versus pressure versus atypical. Okay. So, a structured approach to a non healing leg ulcer emphasizes identifying the cause before treatment. Okay. Next, vascular. Okay, vascular assessment, do an ABI if safe or appropriate, okay? Because if the leg ulcer is in that area, you can't really do a decent ABI, so you should get a duplex ultrasound for venous reflux and obstruction, okay? You can do a toe pressure if diabetes is suspected. Step 3, compression therapy if arterial flow is adequate, okay? If arterial flow is adequate, that's why you need a full vascular assessment. So, compression is the cornerstone of venous leg ulcer care in modern guidelines and public health guidance. Step 4, wound bed dressing. Wound bed and the wound bed dressing, okay? Because actually, venous leg ulcers, they do have a lot of slough. Some of them do have a lot of slough, biofilm, things like that. But dressing matters, but evidence is complex. Systemic reviews highlight how many options exist and why treatment must match the wound characteristics. And when I'm talking about wound characteristics, I mean the exudate, the infection, the peri wound of the skin. Step 5, movement prescription as therapy. Okay. Calf pump strengthening. So that's why physical therapy should be part of leg ulcer therapy. Okay. Ankle range of motion program, supervised walking plan. Okay. Like those adjusted to the pain, patient's pain tolerance, balance, and their PAD status, and peripheral arterial disease status. Seated heel raises if walking is limited. This is not just exercise advice, this is like venous pressure management via biomechanics, okay? And then the 6, the barriers that keep the patient immobile. So for Queen Victoria, today patient, pain control, so that movement is more possible, mobile aids like PT, like physical therapy, risk fall assessment risk reduction, edema management, and caregiver plan for dressing and compression adherence. So, Queen Victoria lesson isn't just about history, it's clinical. Leg wounds don't heal in a vacuum, they actually heal in a moving body. And they fail in a body that can't move. Okay? Well, yeah, that's so, okay? To be honest, because I've seen patients with leg ulcers and they heal because they got hospitalized and couldn't move anymore because they were like walking so much from the swelling, but also because they did not have the right compression dressing, you know? Because a lot of patients that don't have the compression dressing properly, it falls off, right? Because the swelling fluctuates. So when you see a swollen gaiter area, the lower leg, and fragile skin and a recurrent weeping wound, don't just change your dressing, you have to change the physics. So you have to think about activating the calf pump, restoring the ankle range of motion, reducing the venous hypertension, control the edema, and treat the patient as a whole. And that's why vascular should have been on your speed dial, okay? More than anybody else. Vascular. So, because in wound care, movement is an option, movement is medicine. And I hope everybody liked this quick little episode of the Calf Pump and Queen Victoria and our episode of Royal Wounds. And take care of your feet because they take care of you. I'm Dr. D.